Welcome, everyone, and thank you for joining us today. The topic today is The Future is Now, the science, not science fiction, of today's pain management. This is race-approved 1 hour. Our presenter today is Dr. Robin Downing. Dr. Downing is Hospital Director of the Downing Center for Animal Pain Management. She has received many regional, national, and international awards, including the Excellence in Veterinary Medicine in 2001, from the World Small Animal Veterinary Association, and most recently, the 2020 Leo K. Bustad Companion Animal Veterinarian of the Year Award from the AVMA. Dr. Downing is a diplomat of the American College of Veterinary Sports Medicine and Rehabilitation, a certified veterinary pain practitioner, and she was the 3rd veterinarian in the world to earn the diplomat credential in the American Academy of Pain Management, which is a human pain management organization. She was a founder of the International Veterinary Academy of Pain Management and served as that organization's 2nd president. In addition, she has served as president of the American Association of the Human Animal Bond Veterinarians, now called the Human Animal Bond Association. Dr. Downing is an internationally sought-after speaker on a wide variety of topics, including pain management, physical rehab, physical medicine, hospice and end-of-life care, anesthesia-related topics, and overcoming compliance obstacles and issues in veterinary medicine. In 2016, she completed her Master of Science degree in clinical bioethics from the Icahn School of Medicine at Mount Sinai in New York City and Union Graduate College, with the intention of translating the practices of clinical bioethics for application in veterinary medicine. This commitment includes framing the imperatives of the fear-free movement, as well as comprehensive acute and chronic pain management as obligations grounded in bioethical principles. She's now working on a doctorate in clinical bioethics at Loyola University of Chicago. We welcome Dr. Downing.
Thanks, Carolyn. Thanks so much. And thanks to Assisi Animal Health for this opportunity to present just an overview of what we can do now in terms of pain management strategies for our patients. So I really thank Assisi, and I really thank all of you for joining me this morning. This is really quite a great opportunity. It pains me that I don't get to be in the room with you all. That is certainly most of our preferences, but I have to say that I am becoming one with Zoom, so apparently you can teach old dogs new tricks. So I join you from the heart of my hospital, where I get the very best signal for the internet. And so I'd like to go ahead and just get started. So before I give any talk, I really feel strongly that I need to thank and give honor to Dr. Peter Hellier, who was the founding president of the IVAPM, the International Veterinary Academy of Pain Management. And I would respectfully ask that everyone would mute themselves so that we can all hear. Dr. Hellier is an anesthesiologist at Colorado State University, where I am an affiliate faculty, and I have the pleasure of teaching with him every year as we address first-year veterinary students. It's important to me that you all know that I do what you do for a living. I'm actually in small town America, in a town that had 4,000 people in it when I moved here, and only has about 22,000 people in it now, almost 30 years later. My address literally is Main Street, small town America, and in our practice, we are dedicated to this. We're dedicated to celebrating, protecting, and sharing the special love of animals. The Windsor Veterinary Clinic is my primary care practice. The Downing Center for Animal Pain Management is my specialty referral practice in the same physical plant. And this is our practice motto for the Downing Center, that they, meaning our patients, don't deserve to hurt. So it's really our obligation to get them out of pain and make them comfortable. In my first iteration, I was an English major, so I collect quotes from old dead guys. And so the first old dead guy quote today is from Galen, who said, Divinum est opus sedare dolorum. And that translates directly from the Latin, that divine is the work to subdue pain. What we do is truly divine work on behalf of our patients who cannot speak for themselves. Jeremy Bentham, another old dead guy, was a philosopher in the time of Descartes. Some of you remember Cartesian coordinates from geometry. Descartes was the guy who said, I think, therefore I am, and took the position that if you couldn't think, then you couldn't feel pain. So if you couldn't speak, then you couldn't think, and if you couldn't think, you couldn't feel pain. So anybody who couldn't speak couldn't have pain. And that, of course, included animals, infants, and older people who were no longer able to articulate their needs. Bentham said this doesn't make any sense at all. And he was speaking about animals in particular when he stated that the question is really not, can they reason or can they talk, but can they suffer? And of course, we know the answer is yes. Quite a while ago, there was a really cool survey done back in the days when people actually had phones hanging on their walls, and they would actually answer the phone to speak to somebody who was doing a survey. And the survey question, one of the questions in the survey was really about where pets stood in the household. It was gathering information from pet owners about how do you feel about your animals. And at that time, over 20 years ago, 3/4 of those people were willing to tell a perfect stranger at the other end of the phone that my pet is a member of my family. And another 2/3 were willing to say that my pet is one of the most important things in my life. And my very favorite response was this one. In answer to the question, is your pet a better companion than other family members? Do you agree or disagree? Over 50% said, why, as a matter of fact, my pet is a better companion than the other people in my family, which we all know families like that we encounter in our practices. So what about this relationship that we get to serve, this precious, precious relationship, the human-animal bond? Well, I'd like to share this picture with you. This is my mother, Dolores, and sitting on her lap is Andre. And I like to say that my parents really were pretty good parents, and we never got locked in the closet, and we always had food on the table and shoes on our feet. And then I met Andre, and I found out exactly what my life might have been like. Andre wanted for nothing. What Andre wanted, Andre got. And when my mother was diagnosed with stage 3B ovarian cancer, and she was given 6 weeks to live. It was Andre who gave my mother a reason to wake up in the morning. And it was Andre who provided my mother with a focus beyond her next TBC or her next chemo. And when my mother died nearly 7 years after her diagnosis, it was Andre who was at her deathbed in the hospice wing at the local hospital. And it was he who accompanied her across the Rainbow Bridge. This is the precious relationship that we, as veterinarians and veterinary healthcare workers, have the pleasure and the privilege to serve. So what does that mean for us? It means job security. And even in the face of this crisis, I'm not sure if you are all aware that just last week in the New York Times, there was a story about the fact that veterinarians and veterinary practices are actually booming in this time of the pandemic. And I would actually suggest you search with your whatever search browser you like to use. And if you just type in New York Times veterinary practice, that will be the first hit. You should be able to read that article without having to go behind the paywall. It was a very insightful article, and it was a very interesting insight into how our clients are reacting and responding to the animals they share their homes with. And in fact, my practice is not immune. We have seen an uptick in new people in our practice and a resurgence of interest in patients that we thought might be lost to us. I think that the pandemic has put many, many things in perspective, and people's relationships with their animals part of that perspective. That makes our dedication to pain and pain management and pain relief even more important. I think it's important for us as veterinarians and veterinary healthcare workers to remind ourselves periodically that we're the only medical profession in the world that deals with its patients from the very beginning of life to the very end of life. We really provide womb to tomb care. No one else does that. And it places us in such a unique position to watch the entire arc of life. And that gives us an opportunity to do this, and that is to practice medicine as a form of friendship. Human medicine that we as veterinarians have followed for generations, there's been a real shift away from the importance of relationship. And there are many, many physicians who are leaving medicine or who are leaving life by ending their lives because of their frustration that they are not able to have the same relationships with their patients. We have such a unique opportunity to build what we do on that relationship. So shifting my focus to pain, sometimes I rue the day when I was taught that pain was a pretty simple, straightforward process. I miss those days because now we know that it isn't quite so simple. But in the day, back in the day, you could put your foot B into fire A, and then there was this signal that went up the train track C to the part of your brain that actually perceived pain. And that's what we thought for such a long time. But now, come to find out, pain is a lot more complex than that. And that's what's currently being taught. And really, it's very refreshing to see. So the International Association for the Society of Pain is the organization that everyone depends on for defining what is pain. And their definition includes this: an unpleasant and emotional experience that is associated with actual or potential tissue damage. And it really, to me, is such an irony that it was not that many decades ago that this second sentence was added, that the inability to communicate does not negate the possibility that an individual is experiencing pain and is in need of appropriate pain relieving treatment. This was actually a fairly controversial sentence to add to this definition. And of course, in retrospect, we have to ask the question, how could that possibly be the case? Well, so pain in people and pets. Here's what we know now. Pain is very complex and very multifaceted because there's the sensory informational component, that's the physiology of pain. But then we have the emotional dimension, and that's the suffering piece. But then we have this third piece that is goes by the label of cognitive or evaluative component. And this is where the thinking part of our experience with pain kicks in. So the attention to pain and what our previous experience with pain is, and what's the perceived threat to the individual. So that leads us to then ask the question, why is pain so important? So another old dead guy, Albert Schweitzer, who was a physician and humanitarian, said this: the pain is a more terrible lord of mankind than even death itself. And even the Buddhists have said that while pain is inevitable, suffering is optional. And that's really where we come in to prevent suffering. So understanding that pain is complex, we also recognize that it is scientifically very intriguing, clinically challenging, and for us, easy to overlook many times because our patients do not self-report. But it's worth making changes to improve the treatment that we're able to provide our patients, because what we really want are patients like this who are quite happy. So in order to understand a little bit better about why it's important to manage chronic pain and why it's important to take care of pain in the acute phase before it becomes chronic, here's a great study that really articulates why it's important to stop chronic pain before it even happens. So total knee arthroplasty, total knee replacement, is acknowledged to be the most painful orthopedic procedure that humans undergo. And in this study that was done, there was a continuous femoral block that was done for 2 days that was instead of parenteral opioids. And the control group got parenteral opioids, the standard of care. And then they asked the question, was there a difference between cohort A and cohort B? Here's what they found. In the group that had continuous femoral nerve block, for 2 days, those patients had improved pain relief for the first 2 days post-op. But here's where it really kicks in and becomes very interesting, because 40 days later, those people who had a femoral block just for 2 days right around surgery had improved improved range of motion, and they had an earlier discharge from rehab. This was actually a study that was done way back in 1999. Now, some of you may have your brains racing ahead and say, wait a minute, local pain relief in the knee for 2 days, where have I heard that? Well, it's this kind of study that was part of the foundation upon which the use of Nocita was built. And now we have Nocita, which gives our patients who have stifle surgery the opportunity for a prolonged period of local pain relief to do what? To prevent that pain from becoming chronic pain. We know that if we don't pay attention to pain, we go from a beneficial place, pain that helps us survive, all the way to the end, if it becomes unbearable, that we can get pathophysiologic effects. And in reality, pain can kill. The other piece of this that makes things a little complex is that we now understand that the spinal cord is not just a relay station. It's not just a train track that carries a pain signal from where the pain happens up to the brain, but it actually changes the experience of the pain on the way up that spinal cord. So Clifford Wolff, who's one of my very favorite pain researchers ever on the human side, is really the guy who gave vocabulary to a concept of discriminating between adaptive pain that helps us survive and maladaptive pain, which is pain as disease. So adaptive pain, really he breaks this down into 2 categories. Nociceptive pain, which is that transient pain that when we put our hand on a hot stove, our nervous system says, please pull your hand away or you're going to burn your hand. That helps us survive. That's nociceptive pain. Inflammatory pain is really related to tissue damage. And this can evolve into spontaneous pain or hypersensitivity to a pain response after the tissue has healed. So it's inflammatory pain that I call our gateway to chronic maladaptive pain. And the 2 types of maladaptive pain that Clifford Wolff defined were these: neuropathic pain, which is pain that is really generated by and sustained by the nervous system itself, can be associated with damage to the nervous system itself. So think about a fracture where the nerves in the periosteum are damaged. Think of an amputation where a nerve is cut. The other category that Clifford Wolff articulated about maladaptive pain is functional pain. And this is pain that actually has its origins in the central processing in the nervous system, so in the brain or in the spinal cord. This is really pain that is only clearly identified by functional MRI or by self-reportage. And so I'm not sure that we in veterinary medicine will be identifying functional pain anytime soon, but there is work being done right now by many people, one of whom is Dr. Hare at Duke University, who is actually putting border collies in functional MRI units while they're awake, stimulating them with various stimuli, auditory and olfactory stimuli, visual stimuli, and watching where in the brain do things light up. So he actually is mapping the canine brain. So at some point, we may actually be able to identify functional pain in our patients. What we're really talking about, though, when we talk about dealing with acute pain before it becomes chronic, is preventing this phenomenon that we have come to call windup, which is this: a sensitization both of the periphery and the central pathways in response to an unchecked afferent barrage of signals that result in an expanded field of pain and increased rate of nervous system discharge. The patients we see who already have chronic maladaptive pain, they have this. And we need to unwind their wind up, because this is the essence of maladaptive pain. And this is my signal to myself to remind you all that cats are not small dogs. And so while much of what I'm going to talk about does apply to both cats and dogs, it's very important to remember that cats have their own special needs. And they are, in my experience as a pain expert, much more difficult to identify and articulate just where are you painful and how can I help you with your pain. We are a cat-friendly practice, and so we see a tremendous number of cats. And even today, after all these years, I still find myself challenged by them. So how do we make a pain plan? Well, it's like any other plan we would make. It's like any other diagnosis that we would make. We begin at the beginning. And that means a thorough examination, including a metabolic profile. We have to make certain that we know what's going on with our patient, both inside and out. We want to create an appropriate diagnostic plan. And part of that plan may include radiographs right at the beginning. Often if I have a patient who's extremely painful, I will actually postpone my imaging until I have that animal's pain at least ramped down a level or two so that they are going to be more comfortable being manipulated for radiographs. But my point being, you don't want to be treating an osteoarthritis patients, or so you think, and then find out that they actually have osteosarcoma. I've had a number of patients referred to me as osteoarthritis patients who ultimately turned out to have osteosarcomas that were undiagnosed because there were no radiographs taken. So don't be that doctor. And then we want to treat the treatable. And that means treating all the treatables. So it's very important for us to identify if our patients have any kind of comorbidities and deal with those comorbidities all at the same time. We need to make a plan and work a plan. And that plan needs to be written down for the medical record so we remember tomorrow what we said today, but also written down for the client, because the client, of course, is an absolutely critical partner in making a pain plan happen. We also know that a chronic pain plan really has to be a multimodal pain plan. So it's just no longer appropriate to throw a nonsteroidal or two at a patient and call it good. We really do need to multitask, and we cannot do this without the cooperation and the partnership with the client. This circles us back to that emphasis on how important the relationship is that we have with our clients. So when we kind of tease out what are the elements of a pain plan, it's important to remember that most of our chronic pain patients are less active and they're often overweight. And the most important PT we can do with those patients is normalizing their body composition. And I never talk really about normalizing body weight, because I feel like that's a deceiving term. And with what we know now and with the nutritional guidelines that we have available to us, we now understand that it's far more important for us to think about muscle condition scores and body composition scores rather than just looking at a number on the scale. We want to make sure that if we're dealing with a canine patient that we're going to diagnose and treat any hypothyroidism. Hypothyroidism will certainly undermine anything that we do on behalf of our patient, because the patient won't be able to metabolize medications properly or metabolize nutrition properly. And when we choose a nutrient profile that allows us to remake the body composition, it really is important that we follow the science and that we downregulate the obese genes and we upregulate the lean genes. And there's really a tremendous body of information now in the nutrigenomic category. So I would guide you all to have an updated appreciation of what nutrigenomics really means. Then we look at breaking the pain cycle. And it's important to remember that while I'm going to talk about things far beyond nonsteroidal anti-inflammatory drugs, NSAIDs still form a cornerstone of pain management, particularly in the initial stages of managing chronic maladaptive pain, because they do decrease inflammation and reduce pain by acting not only at the site of inflammation, but also at several places in the nervous system. So we need to take advantage of that. And despite marketing hype to the contrary, there's no one best NSAID. There are NSAIDs that some animals cannot tolerate, and failure or sensitivity to one NSAID does not mean necessarily that they won't be able to take any NSAID. I will also say, though, that in my pain management specialty practice, if I have a patient who fails, meaning is sensitive to two NSAIDs from two different classes, I typically do not challenge them with the third. Once the strategic plan for pain management is in place from a multimodal perspective, then we have the opportunity to take the NSAID component and titrate it down to the lowest effective dose. But as Dr. Duncan Lascelles, who gave a wonderful seminar last week, has published in a really elegant study that he did, where an NSAID was the only therapy that was offered, he proved really beyond any doubt that if we only have NSAIDs in place, we really cannot reduce the dose and keep our patients comfortable. So what else could we use pharmacologically? Well, from a pharmacology standpoint, we have to remember that chronic pain is maladaptive, maldynic, pain as disease. And what does that mean for us as practitioners? It means we have to target the dorsal horn of the spinal cord. Because remember, the spinal cord is not just a train track anymore. That dorsal horn really modifies the pain experience by modifying how that afferent signal is interpreted by the thinking part of the brain. So targeting the dorsal horn, targeted therapy, this is even still a new concept in human medicine and is an even newer concept in veterinary medicine. So it's really an important concept that allows us to expand what our pain management strategy really can be. Toward that end, there are two drugs that I use to target the dorsal horn, and the first and most important is gabapentin. Gabapentin works at an exquisitely specific place in the dorsal horn of the spinal cord by affecting the alpha-2 delta subunit in the calcium channel in the dorsal horn. And what that really does is change the influx and the efflux of calcium in and out of the neuronal membrane. And what this drug does is to serve as a very important component of a pain management strategy for chronic maladaptive pain in humans. Post-herpetic neuralgia, or shingles, is probably the most important application for gabapentin in people. What we also now know in dogs and in cats as well, who are dealing with chronic maladaptive pain, is we have to dose appropriately. We have a study, I and three other authors have a study that is in review right now that hopefully will be published within the next couple of months. That was a retrospective study done in my pain management specialty practice, where we looked at over 250 dogs who had been treated for chronic maladaptive pain with gabapentin. And this is really our attempt to get appropriate dosing out into the literature. I start at 5 to 10 milligrams per kilogram, 2 to 3 times a day to start, but we have to do regular dose escalations to effect. And the effect we're after is comfort. It is a myth, and I'm not sure how this got started, that you just don't see effects from gabapentin for a week or 2 weeks, and that's not true. You see activity of this drug within 24 to 48 hours, but you don't see peak effects until we get out 5 to 10 days. And what that means for my patients is that I don't reassess them after a dosing change until they're out about 10 to 14 days. The only relevant side effect for gabapentin in our patients is sedation. In human patients, we worry about things like hallucinations, but I've been using this drug aggressively in my practice since it came off patent now almost 20 years ago, and sedation is the only adverse effect, in which case we reduce the dose. We don't take gabapentin away. It is very important to understand that with gabapentin, we cannot abruptly discontinue this drug, because if we do, they will have a phenomenon called the rebound pain, where their pain re-escalates and can actually end up worse than where we started. And the other issue that, of course, would be on all of our minds is these are older patients typically. Do we need to worry about the liver and kidneys? And the answer is no. In the human arena, in the human literature, it talks about modifying the gabapentin dose in people who have renal insufficiency. But they're talking about people who are on dialysis waiting for a transplant. And this is not the population that we serve. The other drug that I use if I'm targeting the dorsal horn is amantadine. It is an NMDA receptor antagonist that complements an NSAID, and it also complements gabapentin because it works in a different place. 2 to 5 milligrams per kilogram per day for dogs is the dose that showed up in the JACVIM. It's a really nice article by Dr. Lascelles et al. It is very well tolerated long term. The only way it's affordable is to have it compounded. But I will tell you that with the multimodal pain strategies that I use, I actually rarely reach for amantadine anymore. I did years ago, but now with the other tools that I use, I just don't find that I need it very often. Another drug that we can use to help us break the pain cycle is the polysulfatic glycosaminoglycans, in this case, adequate injectable. What I'm about to tell you is definitely off-label. So I do use it in both dogs and cats, totally off-label. But reminding ourselves that PS gags are the building blocks of cartilage. So you don't replace the cartilage that's already gone, but heals the microfractures that occur as osteoarthritis progresses. And as a consequence of healing those microfractures as an indirect anti-inflammatory effect. So how do I use it? I use it the same for dogs and cats, 2 milligrams per pound, but note that I have it injected sub-Q and not IM as is on the label. After now over 2 decades of using it this way, I can tell you that this is a very effective strategy. I use it 2 times a week for 4 weeks, and then I use it once a week for 4 weeks, and then every 10 to 15 days. And often I'm asked, how do you choose between using it every 10 days or every 15 days, twice a month? And my answer is simple. I rely on my client, because if the client notices that the dog or the cat is decreasing some of the activity at day 12 or 13, this is an animal who clearly needs to have their adequate a little more frequently. We do inject sub-Q, and this means teaching the client how to do it, and they do it at home. And remember that PS gags help us heal damaged cartilage as the cartilage is being damaged. It does not replace cartilage that is already gone. So we want to start using it as soon as possible, and certainly long-term use is just fine. Remember that those molecules are able to find their way into all of the synovial joints. So not just the traditional synovial joints we think about, hips and knees and elbows and shoulders, but all of the facet joints as well. So this really is an effective tool for us to help our patients with back pain. And once again, cats are not small dogs, but this is one of those tools that I use in cats as well. So what about non-pharmacology? What about other strategies for breaking the pain cycle? Well, if we're going to use nutrition and nutraceuticals, which I believe we absolutely must, we have to follow the evidence. It's really important for us to be data-driven doctors. So look at your therapeutic nutrient profile. You want to make sure that we do now have therapeutic nutrient profiles that have been proven in clinical studies to assist dogs and cats who have osteoarthritis. But in addition, we want to look at omega-3 fatty acids in a triglyceride formulation, because the esterized form is not bioavailable, at an appropriately therapeutic dose. Another molecule that can assist us with the pain of osteoarthritis is undenatured collagen type 2, or UC2. UC2 is a fairly new entry into our armamentarium against pain. And in a rat model of OA, what the UC2 molecule was demonstrated to do was to slow the deterioration of articular cartilage. How this works, it's a very unique mechanism of action, because it actually works by modulating the immune system. So they call this process oral tolerance. And what happens is that the lymphoid tissue in the gut, those little Peyer's patches, are stimulated, and it stimulates the recognition of type 2 collagen. And what that ends up doing is helping the immune system actually create anti-inflammatory cytokines, which is pretty strategically kind of it goes into the back door of dealing with the pain from osteoarthritis. And in the studies that were done in humans, dogs, and horses who had radiographic evidence of osteoarthritis, there were significantly positive outcomes. So another tool that we can use from a non-pharmacology perspective is a milk protein that's extracted from the milk of hyperimmunized cows. We've known about the anti-inflammatory effects of milk for generations. But what this particular molecule does is to, inhibit cytokines, which then in turn inhibit neutrophils from migrating to sites of inflammation. So what this ultimately ends up doing is blocking the upregulation of inflammation, and so that decreases the destructive chronic inflammation associated with osteoarthritis. This is a different mechanism than how NSAIDs work, and a different mechanism from how steroids work. So what that means is that we can use this milk protein with a nonsteroidal or a corticosteroid to supplement or complement what those drugs do. This is a molecule that does take time to have a peak effect, typically by about 2 weeks. And so we overlap its use with other modalities. So I will overlap its use with my nonsteroidals, knowing that once this molecule is doing its duty in the body of my patient, I can begin down regulating my dose of nonsteroidal. So this is where we establish good pain relief and then begin titrating down that dose of the anti-inflammatory, whether it's a nonsteroidal or cortisone. And there are really few side effects that are reported. I really have only had one side effect in my practice, and that's a GI side effect. And of all the dozens and dozens of patients in my pain practice who are taking this molecule, I can count on fewer than 10 fingers how many patients have not been able to tolerate it from a GI perspective. So then we look at a molecule that comes out of green lip mussel, or the specific species of Perna canaliculus. This is a very interesting molecule because it actually is a little more complex than a single element that allows it to have its effect on the body. It's a palette of bioactive lipids that include the essential fatty acids. And in one of the formulations, it is actually complemented by a hyaluronic acid molecule that is a very specific molecular weight. And this is where, without relying on speaking a brand, I will just alert you all that we have to make certain that we are looking at formulations that utilize molecules like this, or utilize elements like the Perna canaliculus, that are manufactured in a way that does not denature them or interfere with efficacy. And that means demanding that that formulation is evaluated in our patients in the target species for the conditions that we are looking specifically for help. With all of the nutraceuticals, this is important. It is the formulation and not the ingredient. This is one of the things I find most offensive about the nutraceutical industry right now, is that it's very, very easy for an organization to come to us as veterinary professionals with sexy marketing materials about how they added this ingredient or that ingredient to whatever magic potion they've created, but they've never actually evaluated that formulation in the species that are relevant to us, because we want our patients to be comfortable, just like this dog. So what else can we do to break our pain cycle from a non-pharmacology perspective? Well, let's not forget physical medicine, and we have all kinds of very cool strategies that we can leverage on behalf of our painful patients. Any one of these will be a very effective tool for us to use, and many of these don't require additional specialized training for us to leverage in our practice. Another, though, is the use of targeted pulsed electromagnetic field therapy. And I want to provide a few details about this because this is a fairly new entry into the evidence-based medicine portion of our pain management pharmacopoeia, if you will. So how does pulsed electromagnetic field therapy work? So first of all, it isn't only about it being pulsed. It's about it being targeted very specifically. So what happens when we do that? What happens in tissues? Well, one of the things we see happening, because we now have tools to measure these things, is we get increased calcium signaling and a decreased production of nitrous oxide. And it's this combination that decreases inflammation overall. And by decreasing inflammation, we decrease pain. The other thing that I find really fascinating about this technology is that we can actually increase the activity of osteoblasts at the site of fractures. And so we can actually enhance fracture repair by using a non-invasive strategy like this. And this is just a picture of how would a client use this at home in a dog who's got an injury in the carpus. How can we use this targeted pulsed electromagnetic therapy to actually focus on the area of the injury? So from a physiologic perspective, this decreases inflammation. It's going to decrease both acute and chronic inflammation. So the acute inflammation of a sprain, a strain, or a fracture, the chronic inflammation that we're talking about from a maladaptive perspective. It's been proven safe, in addition to being a very effective, but also a non-invasive way for us to engage the owners. So this is something that my clients will use in the days between the times that I see my patients. And it's important for us to remember that our clients, pet owners, want to participate in their pet's care. They want to have an active role, and they really do appreciate being able to do something every day that is positive, that's going to help their pet each one of those days. And this also is a very important way, I think, for us to really enhance and strengthen the human-animal bond, because this actually does build the relationship that these people have with their pets, cats or dogs. So now we have, in addition to using targeted pulsed electromagnetic field therapy for pain, inflammation, fracture repair, we now have additional data that lets us know that this can help us with both seizure management and anxiety management. Different frequencies, but the point being the same. And what we can do, and this is one of the things that we veterinarians do all the time by looking to the human literature, is that we extrapolate so that we can make rational extrapolation choices about other patients that we can help, other patients that can benefit from what we know about an application of a technology or a particular physiotherapy technique for one kind of patient. We can often extrapolate to other patients, and in this case, to explore the use of this tool for other inflammation-based conditions. And this would include things like cystitis or pancreatitis or prostatitis, or to help us with wound healing. An interesting thing about some of the data from the human side is that this very therapy has been proven to decrease proteinuria in humans. So that helps us understand that we might have a positive application for chronic kidney disease. Decreasing pain and inflammation following breast surgery in humans. Actually incorporating the loops into the bandages on a woman's chest post-mastectomy. Decreasing prostate volume. This was really interesting to me because they used a canine model for benign prostatic hyperplasia. And this therapy was, this technology was proven to decrease prostate volume. So that, again, speaks to potential applications for us. And now we also have a published study for use in IVDD dogs post-laminectomy for both pain relief, and that we find that we get an increased effect with longer treatment. So this really lets us know and drives us toward using this technology post-spine surgery. We now have the option for literally whole body treatments. And so we have one for dogs and one for cats. And then the calming application, the dog wears a special vest that actually allows the loop to be positioned like a halo. And here's a dog looking particularly angelic with his calming application. So back to non-pharmacology. What else can we think about? Well, one of the things that I talk to my clients about a lot is about using assistive devices. It's really, I think that we have a bias in the veterinary world that we don't reach for assistive devices like wheelchairs, whether it's a two-wheel or a four-wheel wheelchair, until we have a patient who like literally can't move. And I really feel like sooner is better than later for intervening with these kinds of devices. I will tell you that I try really hard not to speak brands, but I feel it's important to understand that among the supportive vests that are out there, the rough wear vest really does provide the easiest on and off for clients, and really the easiest way to assist a dog patient who is having mobility problems. And then rolling carts or wagons if need be. I love sharing Chomo with my colleagues because Chomo was a great example of why should we intervene early. So this is Chomo, and she was 11 when we took this picture. She's a lab. She was showing us signs of degenerative myelopathy, which many labs, if they live long enough, will do. This is a canine cart from the Canine Carts West Company out in Bothell, Washington, and it's made with carbon fiber and aluminum, so it's really, really light. And I want you to notice that Chomo's back feet are flat on the floor. So we provided her with this assistive device long before she lost the ability to walk altogether. And what we were able to do by putting her in the cart early is within 2 days of learning how to use this cart, she was back to running with her owner 2 to 3 miles a day, using all 4 feet. As her disease progressed, we then used slings to put her feet up off the ground so she didn't wear her toenails away. And when Chomo died, she was almost 16 and she died of end-stage renal failure. So she used this wheelchair for almost 5 years. It was just amazing to watch. So something else that I think is easy for veterinarians to miss is educating our clients about modifying the home environment and home activities. Please make sure that your pain patients, cats or dogs, have their food and water dishes up about the height of their elbows. Make sure that you're talking to your clients about covering slippery floor surfaces and modifying access to stairs. And something as simple as using a ramp to get in and out of their vehicle. And you may actually have to have them modify play with the other pets in the household. If we have a very old dog with a very young dog in a household, we may have some tussles that would actually be harmful for that older dog. The same goes for cats in a mixed generation cat household. Just be sure to educate your client about those things. And don't forget to give your client specifics. They need homework. So you want to be as specific as possible and write everything down. I'm 62 now, so I write everything down because I know I will forget. But mostly, I want to make sure my client has something in writing that they can take home and really cogitate and really incorporate into their own activity. It's very interesting to remember that when we are in an exam room with a client, all the literature lets us know they will remember 10 to 15% of what we say, and we can't predict which 10 to 15% they'll remember. I also ask my clients to keep an activities of daily living diary, an ADL diary, so we can really track over time what is that pet doing in the household. So directing our attention toward pain really means what are the trends? That's why the diary becomes so important, because I'm fascinated by what the pain score is today or what the activity level is today, but I'm even more fascinated by what has happened over the past 2 weeks. And it's those trends that guide our therapy and let us change as the patient changes. So as I wrap this up, I want to circle to pain and its relationship to FAS, to fear, anxiety, and stress. Sometimes we have patients that give us unacceptable behaviors at home or in the exam room, and we have to always think that these behaviors could be pain related. Because what we now know is that anxiety makes pain worse and pain makes anxiety worse. So if we have an animal who is painful, they anticipate that anyone touching them is going to make them more painful, and that can really drive them into FAS. So we have to look at the whole patient and ask lots of questions and really listen to our clients for clues. We should really listen for phrases like, she doesn't like me to pet her there, or I used to be able to groom my cat and now I can't. Another thing is that everyone wears a camera in their pocket now. And so ask for pictures of the home environment. Ask for videos of that animal's activities of daily living. Older dogs, older cats may be fearful because they're painful. Because here's here's just a sad fact. Animals are patients. They really can't, and they don't anticipate or fear their own death, but they absolutely do anticipate and fear pain. And it's our obligation morally to recognize that that can happen. So any pet that's reluctant to be handled has to have the benefit of our concern that they may in fact be painful. So we just need to keep an open mind. We need to take a considerate approach to how we handle our patients and invite those animals to participate in their own care. By forging ahead, we just will escalate their fear, anxiety, and stress. And honestly, from a bioethical perspective, we have an obligation to treat our animal patients as a physician would treat nonverbal children. And that is how nonverbal children are treated now. They are invited to participate in their own care. It's important for us to identify need versus want. If we have a patient, we absolutely need something, we may have to forge ahead. But if it's a want, it may mean reevaluating and coming back and doing that procedure at a different time. It really is time for all of our profession to be fear-free from a biological perspective, from a physiologic perspective, with respect to our patients, but from a bioethical perspective as well. And so